tonight.
We were in Florida, and suddenly I have blood in my urine, and a significant amount. So we went to the urologist and discovered that we had bladder cancer.
An ABC 27 special presentation.
When I was 59, we detected some abnormality in my prostate. He called me back and said, "Gary, you have cancer of the prostate."
Men's Health, a matter of fact. Sponsored by Penn State Cancer Institute.
Good evening, I'm Deborah Pinkerton. You may have noticed your male friends haven't been shaving the last few weeks. They may be doing it to support No Shave November with the goal of creating cancer awareness. Tonight we're here to discuss two types of cancer that more commonly affect men: prostate and bladder cancer. Other than skin cancer, prostate cancer is the most common type of cancer in American men. In 2016, the American Cancer Society estimates there will be more than 180,000 new cases of prostate cancer and nearly 77,000 new cases of bladder cancer in the United States. More than 58,000 of those bladder cases will strike men. What symptoms should you look for, and who is at risk for both of these cancers? Well, you will find out tonight. And if you have questions at home, the host of ABC 27's Good Day PA, Amy Kem, is here to tell you how to get them answered. Amy.
Thanks, Deborah. Specialists from Penn State Health Milton S. Hershey Medical Center are in the ABC 27 call center to answer your questions until 8 o'clock. You can call the number on the bottom of your screen, or you can email your question during the show to questions@abc27.com. Dr. Paul Smith will answer your emails throughout tonight's show. All calls and emails are confidential, and I'll be back later in the show to share some of those questions with you, Deborah.
Thanks, Amy. A Lebanon County man was adamant about getting his prostate checked. His father had prostate cancer, and he wasn't sure if he would be next in line. Here's Gary Young's journey. 67-year-old Gary Young goes to work in style.
It's a 63 Buick Riviera. It's 2 tons of metal and gets 4 miles to the gallon, but it's my little toy.
A passion that has become his career. He's been selling cars for nearly half a century.
As long as I feel good and get up every day and go have some fun and help take care of people like I've been taken care of and give back some of my expertise to them, I'll stay with it.
This vehicle just came out. It's in between the Encore and the Enclave.
A dedicated salesman with a sales pitch that has earned him the title of top Buick seller in the country a couple of times. Now he has another goal. His sales pitch is personal.
Life. Life is my goal.
Gary wants other men to realize how a simple physical and a blood test saved his life.
My doctor checked my prostate every year since I was 40 years old. We detected when I was 59 going on 60 that there was some abnormality in my prostate. So he suggested that I have some further tests done.
Go ahead, get it done. You know, I didn't want him to wait. You never know what's going to happen.
He got me in pretty quickly. I had the biopsies done through the med center and waited for the results for a couple days or a week. He called me September the 9th, 4:15 in the afternoon. I was standing out back.
I just looked at his face, and he just got all white and had to sit down. And when he got off the phone, I said, "Gary, what?"
He said, "Gary, I got some that's good news for you." He said that you have prostate cancer. You've got 4 out of the 16 cores showed cancer in them.
It scared me, it really did.
Doctors diagnosed Gary with early stage prostate cancer.
In Gary's case, we can see a dark area on the right side of the prostate, which is where his cancer was, which was still contained within the capsule of the prostate, and no other evidence of disease outside.
I just thought right away, it's like, after all these years of hard work and, getting close to maybe the end of my career, and all of a sudden my world's going to come to an end. And, because my dad had prostate cancer, I lost some clients and friends with prostate cancer over the years. So I thought, this is it. But I got to think positive. I got to think that God's not ready for me yet. So
Gary's very healthy, leads a very active life. And when we look at anticipated life expectancy, it was estimated at 15 or 20 years. So based upon how much cancer he had on the biopsy as well as the life expectancy, we really talked about active treatment. So we really talked about two options, which was radiation therapy or surgical removal of the prostate.
He just didn't know what to do. And I told him, I said, Gary, get it out, then we don't have to worry about anything.
after all the little research and the reading till 2, 3 in the morning and not sleeping for a week, decided to go and do the Da Vinci procedure.
He elected to undergo the robotic surgery, and so the robotic surgery is a several-hour-long procedure. It's a laparoscopic procedure whereby we put several small incisions on the belly cavity, introduce trocars into the abdomen, and then do the entire surgery through those small holes using small microscopic instruments with 3D visualization.
A surgery date was set.
I said, yeah, I want to do it this day because I'm Catholic, so it was a holy day, the Immaculate Conception, so I think the Mother of God, with her guiding hands, will help you and direct your hands in your operation procedures.
I wasn't nervous for him going under or anything like that because I knew he'd be okay. I just wanted them to get it all. That's all I thought about. Just completely get it all, in which they did.
There was no evidence that any of it had violated the capsule of the prostate. So they looked at the capsule and they found that the integrity was okay. There was no cancer that was cracking through there, and his lymph nodes that were located on either side of the prostate showed no evidence of any involvement.
I had prayed and prayed, and I just knew that the Lord would answer, and he did. He came through it wonderful.
A week after surgery.
Hey, Laura. Could you run that deal for me then for Renee?
Gary was back at work.
The one we did the other day, remember we just did the retail order?
I feel good. I'm still working 50, 60 hours a week, which I shouldn't be doing, but I still am, and I feel great.
Back seat now has heated seats.
Now Gary is not only selling cars to customers, he's sharing his story too.
To me, it's prostate day every day. But I, again, give them my thoughts of my personal experience and what I went through, and then the testing and the checking, and don't drag your feet about it. You know, tackle the situation right away and get it done. Just because you have it doesn't mean you're not going to be around. If you get it looked at, you'll be fine.
Spreading the word about prostate screening is Gary's goal. He wants men to realize how simple the tests are. Now, here to give us some insight into prostate cancer is Gary's surgeon, Dr. Jay Rahman. Thank you for being here.
Thank you.
Gary had his screening early because of family history. What are some of the risk factors?
So I think Gary's case illustrates one of them, which is a family history. If you're a man who has a father or brother, so a first-degree male relative with prostate cancer, your risk is roughly double that of the general population. Age is another risk factor. Certainly men over 65 years of age have a significantly greater likelihood of being diagnosed, and we need to keep in mind race and ethnicity. Certainly Black and African American men not only have higher rates of prostate cancer, but aggressive prostate cancer.
And what about symptoms?
So at early stages, prostate cancer is largely asymptomatic. So a lot of the symptoms that we think about, dribbling, urinary frequency, and urgency, that's mostly attributable to an enlarged prostate, or BPH. A lot of symptoms from prostate cancer itself is unfortunately late-stage prostate cancer, where patients may have bladder or bowel dysfunction, lower extremity weakness, and bony pain. And that's really why screening is critical, to identify prostate cancer at an early stage when it's not only treatable, but also curable.
And that's what Gary mentioned. It's very early to get screened, and how do you do it?
So we follow the American Urologic Association, our national organization's guidelines at Penn State Health, and that involves checking men between ages 55 and 70 who have an anticipated life expectancy of over 10 years. And screening really happens in two ways. One is a rectal examination to feel the prostate, feel for any lumps and bumps and nodularity, and also a blood test, which is called the PSA, or prostate-specific antigen blood test. And the PSA is secreted by the prostate into the blood, Any man with a prostate will have a PSA level, but high levels can alert us that there's a problem in the prostate. Maybe benign, but maybe cancerous.
So if your PSA level is higher, what is the next step?
So I think the first step is recheck the value, make sure that we're not overreacting to a spurious read. But if we have persistently high PSA values or the rectal examination is abnormal, we recommend a prostate biopsy. This is an outpatient procedure. We take small little snippets of the prostate and we look at it under a microscope, and that allows us to know, are we dealing with cancer, yes or no? And more importantly, if it is cancer, what kind of cancer is it?
And if you are dealing with cancer, is surgery always necessary?
So surgery is certainly one option, but the decision of what treatment we recommend depends a little bit upon what type of cancer do we have. Is this an aggressive versus a non-aggressive cancer? What kind of imaging do we have? Has it spread outside the prostate or not? And that allows us to have an array of options ranging from surveillance to local therapies such as surgery and radiation therapy, as well as systemic treatments such as chemo and hormonal therapy. I would say if someone in Gary's case who is active and healthy, who had intermediate risk cancer, surgery presents an excellent option.
And what about support groups? Are there support groups available?
Yeah, so at Penn State Hershey, we do have a prostate cancer support group that meets on the second Monday of the month and really provides a great peer forum for patients who are diagnosed, who are considering treatment options, or those that have already undergone therapy and are looking for support from others.
Okay, Dr. Rahman, thank you for being here this evening.
Thank you very much.
Why don't we check in with Amy Kim in the ABC 27 call center. I see the lines are busy, Amy.
Yeah, thank you so much, Deborah. The lines are very busy this evening. Folks can give us a call right now at 717-346-3333. And here to answer our viewer questions tonight, we have urologic oncologist Dr. Suzanne Merrill here with me tonight. Here's our first question. Thanks for being with us. This is from a viewer. My father was diagnosed with prostate cancer several years ago. He has received radiation and hormone treatments, but now his PSA numbers are rising. I heard about a treatment called Provenge. Is that how I say it? Provenge. How does this work? Is it an option for my dad?
Sure, good question. So Provenge is actually a cell-based immunotherapy. So a drug that actually causes the body to attack the cancer itself. Provenge is used for patients that have metastatic prostate cancer, which means that the cancer has spread to other sites of the body outside the gland of the prostate itself, and whose cancer is what's called castrate resistant, which means that it's no longer responding to the first-line treatment for metastatic prostate cancer, which is hormone therapy. So in this patient's father's case, I would recommend that they first get an evaluation to understand if we can detect where the prostate cancer may be. As with the rising PSA, there's a suspicion that it has come back. And so once that happens, then we can understand how we can more appropriately treat this patient's father.
Very good. Thank you so much, Doctor. If you have questions at home, you can give us a call right now. That number's on your screen. Or, of course, you can email your questions to questions@abc27.com. We'll be right back.
You're watching Men's Health, A Matter of Fact, on ABC 27, sponsored by Penn State Cancer Institute.
Welcome back. A Lebanon County man was on vacation when he suddenly had blood in his urine. Dave Bishop didn't know what was happening, but he knew he needed to see a doctor immediately. Here's Dave's journey. Dave Bishop and his wife Sue take advantage of this beautiful day. They spend the afternoon on the tennis courts.
Good shot. Another good one.
After a few games, Dave must get to work. It's his job to clean off the courts as an employee of the Hershey Country Club.
Good exercise, for one thing. The camaraderie with people, enjoy being with the people there. And I'm still competitive, so I enjoy the competition. It's a good workout. You play at even doubles is a good workout.
An active lifestyle that was interrupted while they were in Florida playing tennis.
We were on vacation and suddenly I have blood in my urine, and a significant amount.
I called my sister, who was a nurse, and she said, "Does he have pain?" And I said, "No." And she said, "Go to the ER."
The ER doctor said, "Well, it might be a urinary tract infection. However, I think you ought to see your doctor when you get home." being scared right off the bat, we decided we're going to take off right away. And we drove all the way home in one shot from Florida, and then got an appointment with the family doctor.
Our family doctor sent him for some tests, and then he sent them right away to the urologist.
So we went to the urologist and discovered that we had bladder cancer.
Bladder cancer is a cancer that starts in the lining of the urinary bladder. It can also affect the lining of the kidneys and the ureters, the tubes that drain the kidneys.
At that point, you're wondering, well, what's that mean? Am I going to live or am I going to die from this? Cancer word was, something that you thought, that's a death sentence.
It was very difficult, very scary, and very stressful.
How do we go about telling the children and the grandchildren, and how are we going to deal with this?
Dave's urologist suggested BCG to treat the cancer.
BCG is a weakened form of tuberculosis that we use in patients that have non-muscle invasive bladder cancer to try to prevent them from having recurrences within their bladder, and also to try to keep them from having progression to muscle invasion.
Dave underwent BCG treatments for a number of years until the therapy stopped working.
At the point where we first met him, he actually had some disease that had grown into the ureter itself, into the tube that drains that left kidney. All of these are signs of progressing disease and signs that we're no longer really able to treat the patient with the bladder intact.
Quite candidly, he said, well, I think you've come at the right time. I think you just dodged a bullet. It's time for us to remove your bladder.
So what I recommended for Dave was that we remove his bladder and his prostate along with the lymph nodes in his pelvis, which would be the first place that the cancer would spread to. We also wanted to take out his left kidney, which was no longer functioning, and the drainage tube that led from the kidney down to the bladder, which had cancer in it. In order to reconstruct his urinary tract, we would take a small piece of his small intestine, connect his remaining ureter to the one end, and bring the other end out to the skin. He would wear a bag over that opening. The urine would drain continuously into that bag.
He said, this is going to be necessary, and here's the way you're going to deal with that from here on out. You're going to have a stoma, and you're going to have a bag for the urine, and you'll empty it that way, and this is the way you'll be.
My question at that time, I remember that, is that going to get rid of the cancer? And he said, yes. And we looked at each other and said, do it.
You're apprehensive and yet wondering, is this is going to be the solution? So you go through it.
Day of surgery, I think it was like an 8-hour surgery. So that was very difficult. We had friends and family, everybody came in and was sitting with us. And Dr. Kaeg is wonderful when they get through a certain stage, and he comes out, talks to the family, said everything's going fine.
Dave spent a few days in the hospital and a few months getting comfortable with the ostomy bag.
It's an adjustment, and we would have very good ostomy nurses from the med center would help out and say, well, here's how you can do it.
We had to learn how to clean the bag, how to take care of everything.
A new and much better way of life for Dave and Sue.
I'm feeling probably 100% of what I had been prior to this time, and I feel good to be on the court now.
He had his surgery. He has something that he has to live with for the rest of his life, but he's going to live, and that's the important thing.
I am a survivor, and that's the most important thing to me, that when you start talking about cancer, also that tag of survivor is, to me, the most important thing.
Dave is chairman of the Bladder Cancer Support Group at the Med Center. He wants bladder cancer patients to realize you can do almost anything after the surgery, as you could well see. Well, Dave's surgeon, Dr. Matthew Kaeg, joins us. Thanks for being here. He noticed blood in his urine. Is that a sign of bladder cancer?
It's actually the most common sign of bladder cancer. Some cancers present without any symptoms at all. But the majority will have some blood in the urine. We also look for things like urinary urgency, where the patient has to go to the bathroom more frequently than usual, pain on urination, or the inability to urinate.
And bladder cancer, how quickly does this spread?
Unlike prostate cancer, which is a relatively slow-moving cancer, bladder cancer can move quickly, so it's important for men that have blood in the urine to get checked.
how is bladder cancer diagnosed?
So the mainstay of diagnosis is a test called cystoscopy. It involves the surgeon putting a flexible scope directly into the bladder and looking at the lining of the bladder for tumors. This is augmented by CAT scan, ultrasound, and there are some urine tests that look for cancer cells and genetic changes in the cells that are seen in the urine. And these can supplement the cystoscopy and the CAT scan that we order, but don't replace it.
And what about risk factors?
The major risk factor for bladder cancer is actually smoking. The toxins that we breathe in through our lungs get processed and come out through the kidneys and the urine. About 75% of our patients are actually smokers. Male gender is definitely a risk factor. Men are much more likely to have bladder cancer than women. And this tends to be a cancer of older patients. Our average age of diagnosis is around 72.
And what about treatment options for bladder cancer patients?
So treatment options sort of divide along two lines. Patients that don't have invasive bladder cancer, disease that has gotten into the muscle layer of the bladder, can usually be managed with a scope procedure where the cancers are scraped out, and then we use chemotherapy like Dave alluded to BCG. Those are therapies that are placed directly in the bladder. Patients that have invasion into the muscle layer where the bladder cancer now has access to the blood vessels and to the lymphatic vessels that allow it to spread, those patients need to have their bladders removed. And sometimes we'll give chemotherapy in addition to try to augment that treatment response.
But as you could see, you can do almost anything after you have your bladder removed. Dave represents that well,
Right.
and he's chairman of the support group. How important is it to have a support group?
I think it's very important. These are patients that properly treated, they survive and they do very well, but the vast majority of people in my clinic are very worried about quality of life afterwards. And our support group offers a chance for patients to get together and talk. They support each other, they educate each other, and we've gotten involved a little bit more in supporting research efforts and some community service as well.
Okay, Dr. Kaag, thank you for being here this evening. A lot of very good information. Now let's check in at the call center. Amy, how's it going?
A lot of calls are coming in, Deborah, and we have another viewer question for Dr. Merrill here with us. That question is, how common is testicular cancer? Does it always require surgery?
Yeah, testicular cancer is not common. It actually represents only 0.5% of all new cancer cases in the United States. The good news is with testicular cancer is that it's very treatable. We actually get to tell patients that they have a chance of cure in this cancer. Surgery is typically recommended as an initial step in order to diagnose the cancer and to help guide treatment based on understanding the cell type.
Okay.
What's important for men to understand is the awareness to perform self-testicular exams. This cancer is very common in men ages 20 to 34.
Very good. Here, very quickly, one final question here. For the last few months, I've had to urinate more frequently. I read this could be bladder cancer. Should I go see a doctor, or could this be something else?
Yeah, good question. So urinary frequency is not a common symptom for bladder cancer. We tend to more think of urinary tract infections, an obstructive prostate, kidney stones, bladder urgency, etc. But however, if this is a symptom that this patient's having that is becoming more, frequent, bothersome, they should seek evaluation. Bladder cancer, again, is most commonly presenting with blood in the urine or blood seed on a urine analysis.
Very good. Thank you so much, Dr. Merrill, for answering our questions, and thank you for the specialist here in the studio answering questions from viewers tonight. Let's go back to Deborah.
Thank you, Amy. Now joining us is urologist Dr. Susan McDonald. Now, what is your role in helping prostate and bladder cancer patients?
Well, understandably, when patients are diagnosed with cancer, the initial treatment is going to be the initial focus is going to be on treatment and cure. Where I come in is helping with fine-tuning quality of life afterwards. So not every patient who undergoes cancer care will develop erectile dysfunction or urinary incontinence, but for those that do, it can dramatically impact their daily lives. I help restore quality of life and function after the cancer care is finished.
And what are some of the treatments that you offer them?
So a lot of patients are aware of the treatment for erectile dysfunction in the form of pills like Viagra, but not many people know that there's a surgical implant, such as this one right here, for treatment of erectile dysfunction. With these two inflatable chambers, we can place the device in the body and then restore sexual function to a couple who've been affected by a cancer diagnosis.
And what about treatment options for patients that are incontinent?
So a lot of patients who develop incontinence will improve with just simply time. But for those that have persistent incontinence, there's essentially two surgical treatments. One is a sling of mesh that will provide extra resistance to help prevent leakage, and the other is a little cuff that gently squeezes the urethra shut and prevents leakage. Both are designed to help keep the patients dry afterwards.
And what about new research? Is there anything going on now to help patients in the future?
Surgical innovation is always going on. Surgeons have improved their techniques drastically over the last 20 years to prevent these issues. And then we're also working on penile rehabilitation to improve the return of erectile function after surgery.
Okay, some very good information. Dr. McDonald, thank you for being here this evening. And we also want to thank you, our viewers, for sharing your stories and sending in your questions. If you would like more information or you would like to schedule an appointment with Penn State Cancer Institute, call 717-531-6683 or visit online at pennstatehershey.org/cancer. The next meeting for the Bladder Cancer Support Group will be Saturday, January 14th at 10 in the morning. The meeting will be held at the University Fitness and Conference Center. If you have questions about the support group, contact Theta Shaw at 717-531-0003, extension 285863. We want to thank you for watching tonight, and we wish you good health.